Okay, so folks, we're now going to go into the next session 2, inhalation across the ages. So we've just heard from Mike some of the challenges about delivering to a very young patient group. And the committee thought it would be of interest to really start to explore a little bit more about what happens when you go to much younger patients and much older patients. So we have a couple of invited speakers. We're going to start with Dermot, who's going to talk to us about the challenges of aging. And then afterwards, we'll have Louise, who's going to talk to us about some of the challenges about delivering drugs to pediatric subjects. And then some of the work that we had submitted is also going to inform about this, because we have levodopa, delivery of an important drug to folks with Parkinson's. What challenges does the age of the subjects have to that? How do we then build that sort of thinking into the development plan? Okay.
Okay, well, can I add my welcome to that of Gary's? For those who don't know me, I'm Alex Slowey. I'm with Kindeva Drug Delivery, and it's my privilege this afternoon to welcome Dermot Ryan to speak to us. Dermot is a retired GP. He has over 30 years' experience as a full-time GP. His interest in asthma, and hence inhalers, commenced in 1985. He's twice been chair of the Primary Care Respiratory Medicine, and he has led to the establishment of the first chair in primary care respiratory medicine at the University of Aberdeen. He was a founding member at the International Primary Care Respiratory Group, of which he is a director. He has authored or co-authored over 200 publications in peer-reviewed journals. So please welcome Dermot Ryan.
Thank you very much. So I'd just like to say thank you very much also for the invitation for being here. I didn't know precisely what I was going to say, and having seen the high science and there's posters downstairs in the immediate past presentation, can I just say you're all doing fantastic work. So the structure of the talk will be a brief history of inhalers, errors which are made, the support patients need, what do we want and what do we need, and that's not just us but the patients as well. Digital add-ons, what are they? Do they work? Do we need them? And the vision for the future. So first of all, I go through the 7 ages of man according to the Bard. First of all, the infant mewling and puking in his nurse's arms. We've heard a little bit about that already. Then the whining schoolboy with his satchel and shining morning face. And as we get older, the lover and the soldier, full of strange sighs and bearded like the pard. Then injustice, round and fat-bellied, and then the old fella at the end of the story. So thank you, William Shakespeare, but it just points out, in essence, that we need different strategies for different people at different ages of their lives, and every single patient is individual. So a brief history of inhalation medicine, very, very brief. It starts in Egyptian times when they used to inhale henbane. This is how they did it. Moving on to the nudge inhaler, the pulvérisateur, very lovely French term, and in the 1940s, vaporizers, which are also used for dispersing perfume, of course, as you are fully aware. Unfortunately, the single best inhalation device has been the cigarette, and even in the past, various drugs are put into cigarettes in order to try and to give relief to patients suffering from asthma. So in asthma, we saw the first metered-dose BDP inhaler approved by the FDA in 1976. The first trial to demonstrate that BDP was effective in the management of asthma, done by Henry Morrow Brown in Derby General Hospital a couple of years before that in 1971. And the first SABA inhaler that was effective in 1981. But we did see before that the advent of adrenaline and isoprenaline inhalers in 1956, which led to a rash of exacerbations and asthma deaths. So you all know how an inhaler works. The point is that this MDI is highly dependent on the patient's inhalation technique, and patient education in its use is essential. It's really, really, really important. There have been modifications of the MDI with the Easy Breathe and the autohaler, which have helped remove some of the coordination problems that patients come to come with. And then we saw the first adaptation with the spacer appearing in 1957, and then various adaptations since, all of which reduce, in essence, the flow rate of the aerosol plume so it doesn't hit the back of the throat at the speed of an express train, slows it down and gives a chance for more measured inhalation. And it's particularly useful in children and often in the elderly. And then along came dry powder inhalers. The first one was the inhaler that came with disodium chromoglycate. Disodium chromoglycate was a plant-based remedy developed by Roger Altunian from a herb he'd noticed caused some relief of asthma symptoms in Turkey. And it was formulated into disodium chromoglycate and put into this spinhaler, which was given to patients that was all we really had in terms of asthma prophylaxis for many, many years. And it did work to some small extent. It was a mast cell stabilizer. And then we also had nebulizers, jet nebulizers, which are powered by oxygen, and ultrasonic nebulizers, which have an electronic compressor driving the material through the actual nebulizer itself and delivering a dose generally over about 5 minutes, but most people stay attached to it for 20 to 30 minutes because there's still fluid going around, but that fluid is now devoid of any medication. So we're left with a whole variety of different inhaler devices, and therein lies part of the problem. Which one do you choose for the individual patient, or which one would the patient like to use? Oftentimes, they can't use the one that they would like to use. And just to add to the mix, we have the soft mist inhaler, which was developed by Boehringer Ingelheim. It produces a very, very soft mist, which is very, very sympathetic to breathe in, and very, very easy in terms of using it once you've got it actuated. It's environmentally friendly. Many of the coordination problems are removed. It's very good lung deposition, around 55%. And there may be future applications, and I saw some posters downstairs looking at how some of those applications might be developed in the future. So that's good news, because some of the drawbacks are it's yet another device. And mainly this is used in patients with COPD. Many of those are on an inhaled corticosteroid, a long-acting beta-2 agonist, a long-acting muscarinic antagonist, and the only thing that's available for them is a long-acting muscarinic antagonist. So many people with COPD have this. They have a dry powder device, and they nearly always have salbutamol as a rescue medication. Of course, the resulting thing is they don't know what they're doing with any of the inhalers. So let's just look at the errors that people make. In the critical study in DPI users, insufficient inspiratory efforts were common and associated with uncontrolled asthma and an increased exacerbation rate. In metered dose inhalers, the cardinal area was actuation before inhalation of the dose. So you often see people using their MDI and the plume comes out of their mouth or down their nose. You can virtually guarantee that nothing has gone into their lungs. All inhalers demonstrate some failing or another. The biggest one, and it's common to both metered dose inhalers and to dry powder devices, is a failure to empty the lungs prior to attempting inhalation. Now, this is really, really important because if you start breathing in on a lung which is full, you're not going to get the air down beyond the level of the trachea. It's not going to go into the lungs. So you need to empty the lungs in order to create the vacuum to pull the particles down into the lungs. And the number of people who don't do that is phenomenal. And there are reasons why they don't do it. Insufficient breath hold. The particles need 3 to 5 seconds to deposit in the peripheral airways. A lot of people just go, and you've all seen them with their metered dose inhalers in dramas on television when they always take their MDI when they're stressed. Nothing to do with asthma at all. But that's just an observation which many of us have made over the time. With dry powder devices, the inhalation is frequently not forceful enough. And the aforementioned Henry Christian will tell you about the different characteristics of every different dry powder inhaler there is, and the resistance, the inspiratory flow created, and the turbulence, and so on and so forth. But it's different from inhaler to inhaler. But the cardinal thing is that with dry powder devices, a very short, sharp inhalation is needed, because it is that which provides the energy to disaggregate the particles from the carrier in order to get them down into the lungs, except for, of course, the AstraZeneca products, which don't have any carrier in the turbohaler. Failure to put the inhaler in the mouth. The adverts always used to show the inhaler out here, didn't they? The instruction sheet. And the patient grow a plume, suck it up this way. And it goes on, but this hasn't even included not taking the top off the inhaler or spraying the inhaler on the sandwiches in order to take the medication to work. You ask a patient about their inhaler stories and how they use the inhaler, you will have a moment of levity in your day. So specific challenges for the older patient. Well, we recognize cognitive impairment. Patients' memories are slower, their coordination is poorer, and Alzheimer's causes a lot of confusion, which is really why it's very important just to have one type of device. There can be physical impairment of the hands, but also muscles around the mouth, the cheek, and with poor dentition, you can't get a decent seal around the inhaler. Technique goes off over years and needs to be reinforced constantly. And then many patients are reliant on caretakers to give them their medication. Well, the vast majority of those haven't been instructed in inhaler technique, and they may get a different service every 6 hours from a different carer. Other challenges we have are multiple inhalers, polypharmacy, and device understanding because of mixed devices. So some of the solutions are one inhaler type per patient. Shouldn't be too difficult to implement, but I can guarantee that 80% of patients out there are on 2 different inhaler types at least. And it doesn't matter whether it's a dry powder device or a metered dose inhaler, with or without a spacer. There have been cases of patients having dry powder devices and be given a spacer to use it better. Combination inhalers containing 1, 2, or 3 drugs, that helps to reduce the confusion in giving the medications. And for those who really can't make it, then nebulizer can be very helpful. But the difficulties of the patients start with us, clinicians. In healthcare professionals, very few of us know how to use an inhaler properly. And some of us don't know how to use it at all. And if the healthcare professional doesn't know how to use an inhaler, they cannot teach the inhaler, nor can they check the inhaler device technique and make any corrections which may be needed. And this is pretty scandalous, because 10% of patients in any single GP practice will need an inhaler. And of course, then there are mixed regimes as well, so we have to teach them about their particular regime and how they use their inhalers. So which is the better inhaler type? Well, this retrospective real-world analysis looking at the same compound in 2 different formulations, one dry powder, one metered dose inhaler, the same dose in each, although the slide is a little bit misleading on that, demonstrated quite clearly that the metered dose inhaler did get better results in terms of better control and reduced exacerbations. So there's a big move to get rid of metered dose inhalers. The first session we had this morning demonstrated that very, very clearly. But we have to be careful about how we manage that. And if you use mixed inhalers, you are less likely to have control and you're more likely to have exacerbations compared to people who have just one single device. So these are very simple. To you, probably completely illogical that we're even doing this, but it's because of the willy-nilly way in which inhalers has been developed and introduced over the years. And that's not an insult to you. That is the way in which we have chosen to choose them. So metered dose inhalers are multi-dose, compact, less expensive, generally easy to use and quick to use if they're taught properly. But you do need perfect hand mouth coordination, and there's a fair degree of oropharyngeal deposition. Dry powder devices require less coordination. They do require more effort to use, and they're generally better lung deposition. But you do need higher inspiratory flows. Soft mist inhaler, it's great. It does great lung deposition, but it's very fiddly to prepare. I always found it quite difficult. And nebulizers are very flexible, but they take a long time to use, and they're quite expensive, and they need maintenance. The tubing needs maintenance, the nebulizer needs maintenance, and the compressor in particular needs maintenance. So moving on to digital. Should we be adding it in? Is it a success or not? Well, one of the first trials of any form of digital inhaler was done by Matt Cochrane in London in the early 80s. So they gave the patient an inhaler and said it was the same inhaler as always, but it had a device on it to make it work better. And they were going to check whether they were taking the medication, and they were going to check whether they were taking the medication by weighing the inhaler. So when the patients came in and the inhaler was weighed, bingo, they were all fantastically compliant. But the pattern of medication taking was completely random, with the vast majority of people doing 70 to 80 actuations in the hour or two before the outpatient's appointment. They want to keep the doctors happy. We all want to keep our doctors happy. So what do patients want with dry powder devices, whether they've got asthma or COPD? They want a confirmation that the dose has been taken. An empty chamber, an empty capsule, a noise, whatever, demonstrating that the medication has been taken. They want consistent dosing that is accurate every single time. And they want ease of use when they had breathing difficulty. And don't forget, there are a lot of people who have a lot of exacerbations, or even just difficulty periods when they require more reliever medication in particular, but with the advent of MART regimes, more of the combination inhalers. So what is the pot of gold at the end of the rainbow? What kind of inhaler do we want from developers and engineers? We want good lung deposition. We want something that's easy to teach and easy to use. And of course, the patients really want that too. They want something which is environmentally friendly, although that is quite low on the list of priorities. Most patients would much prefer to have something that worked and made them better and didn't have to worry about the environment. They want a counter so they know when it's empty. They want something that provides feedback to them one way or another. And they want something, particularly the payers, want something which is cost effective. And I don't think that's unreasonable. I think we should all aim to be cost effective and with some sort of digital support one way or another. So I think that a blended approach to improving digital solutions is very, very important. So let's just look at two digital add-ons, the Inca device and the DigiHaler. The Inca device is measures the acoustic signal with this device which is strapped on the back here and tells you an awful lot about the patient's inhaler technique. The DigiHaler was used to try and predict when somebody's asthma was getting worse and when they should either increase their dose of their medication or to seek medical attention. And we saw some fantastic patterns. This is a patient with good adherence, with regular use and stable lung function, but you can see from the yellow dots there were some times when the medication wasn't taken properly. Poor adherence, periods of no treatment at all, and with poor disease control. And look at the peak flows in morning and evening with massive variability in their peak flow rates. Good adherence with a reasonable technique, refractory disease. Quite severe asthma, as you can see from the red lines down there, marked up as adverse events. But you can see quite 50% of the time they took the medication at the same time in the morning and the evening. And then somebody who didn't understand what they were doing at all. The inhalation technique was wrong. They took most of the doses at one time of the day. This person wasn't taught how to use an inhaler. That's our fault. And they can be used for monitoring. Now, monitoring is important, and particularly monitoring during treatment and making adjustments to re-establish control. Now, the FACETS trial was a trial done 25, 26 years ago, looking at different doses of budesonide plus or minus formoterol in the control of asthma. And they recorded faithfully their peak flows, their symptoms, and their medication use for a year, 800-something patients, 857 patients. And during that year, these 800 plus patients had 400 plus exacerbations. And the pattern of the exacerbation was the same in everybody. It was marked by an increase in taking their reliever inhaler, it was marked by an increase in night waking, and it was marked by a decrease in their peak expiratory flow. So this particular DigiHaler incorporated some of that, but used peak inspiratory flow rather than peak expiratory flow in order to determine what was happening, and also put in inspiratory volume. And you can see it came up with an algorithm which demonstrated when, you can see as the number of SABA inhalations went up, the peak inspiratory flow fell and the inhalation value fell, and there was a time when the machine learning incorporated in the program told you to increase your medication or seek medical help. So that was really quite helpful, I think, in many ways. The person had an app to go along with it, which of course told them what to do, but that has now been discontinued since June of this year in this country. So what is the potential for mHealth? Monitoring patients over time, providing results to take the healthcare professional, but individuals don't really believe that taking the medication regularly is terribly important. The healthcare professional would like something which helps detect deterioration and advising when to seek attention. But is it really needed? We did a study looking at an app 15 years ago. In the run-in period, the patient we selected, the criteria was patients with an ACQ of greater than 1.5. Nearly one-tenth of the population we had selected over the week between doing their questionnaire and coming in for their randomization visit achieved control because they started taking their medication, or they realized they had poor control and started taking their medication. So sometimes just a nudge in the right direction is important. There was no difference between the two groups, the peak flow paper monitoring and the peak flow digital monitoring. Why? Well, what we did do with both groups was give each individual patient 40 minutes of a standardized asthma education package. Every single patient, they knew that was what they were doing, and we did see an increase in the ACQ in both groups, but there wasn't a paper between them. The IACI position paper, and this resonates with what was said this morning, patient-centered care is really, really important. And patients should be involved in every single part of any trial process or any systematic change in medication giving. From the healthcare professionals, there has to be a mismatch. There is a mismatch between what patients think is going to happen and what we're actually capable of doing. And we're also scared of the burden of work, of information coming into our inadequate computing systems, which could overwhelm us because they're not filtered in any way. Cost effectiveness, the jury's out. Whichever way you use, some systems show a slight benefit and some show an increased cost. So really, there's no clear message with regards to whether it helps or not. The vision is that smart inhalers should meet unmet needs, be accepted by the clinical community in one inhaler device. They're safe, effective, provide quality assurance, there's a willing payer, and it integrates with the electronic medical record. In summary, inhaler technology is continuously improving, and hats off to all of you guys down there. One size will not fit all. Aim for one inhaler type per patient. Digital technology will have a role, but it won't be the predominant role. The clinician is always going to be important in leading the patient on to doing the right thing. End users, patients and clinicians need to be involved in the development, and blended care between clinicians and patients is absolutely essential. Thank you very much.
Well, thank you very much, Dermot. A very interesting talk. We've got time for perhaps just one question from the audience. While we're trying to find someone with a question, I've got one for you. You mentioned the use of apps and smart technology in patient adherence. Do you have any feel for how, choosing my words carefully, patients of an older generation and bearing in mind I already asked my 18-year-old to sort out the television, do you have any feeling for how an aging population would be able to cope with that?
Well, I think we're seeing people in their 80s now using apps very, very regularly. So I just don't see that as a barrier. But if they have dementia, that's a different kettle of fish altogether. So age is not a barrier to using these things. They've all got smartphones. They know how to use them. I mean, of course, there are exceptions. Some parts of the country, people can still barely read and write. Don't forget, the average reading age in the UK is that of a 10-year-old.
Okay, thank you. It's time for maybe just one more question.
So Dermot, thank you very much for that great talk. And I guess Louise will pick up a little bit on the pediatric arena and the influence of digital with respect to aging. So you showed us that the jury's out with respect to the evangelical approach that we've had to digital inhalers, digital apps. So what studies are out there that actually show that they actually truly do work? And all the studies that I've seen are too short and too heterogeneous.
Yes, Omar, the apps do work in a clinical trial situation where the patient is properly trained on them, they know what they're doing, they're followed up regularly, and you see success. But that will not be reflected in the real world. Adherence drops off enormously, as you're fully aware, from multiple studies. The fantastic adherence in the first month of a study, going down to 60% by the second, and by the end is about 30%, which is about the average level of adherence for using an inhaler and taking regular medication anyway. So some people, they drop off because they've learned what to do, they know what to do, they feel in control, and they don't have their exacerbations, they don't have their symptoms anymore, but they don't need the app anymore, but it's there in the background for them to come back to, should they need it, to pick up something that they may have missed before. Others, because they think, this is just another intrusion in my day-to-day life. So I think there's pluses and minuses, and in the clinical trial situation, you're always going to see more pluses than in the real world.
Okay. Thank you, Dermot. I think
and having said that, there was a fantastic study from the Charité in Berlin, looking at the blended care, and they got seeing the patient regularly, either face-to-face or by telephone call, and they got adherence up to 60%. So it can work, but it requires the human interaction as well as a digital interaction.
Great. Thank you again, Dermot.